But influenza and common cold, these are contact things. These are droplet and contact things. They're not airborne. If you now touch that gown with your hands and then rub your nose, pick your nose or something, then you've transmitted it. It's not rocket science, but that is fact, all right? So if you're going to wear a gown, then there's no rule that says you have to. If you're going to do it, you probably want to wear one that comes up to your neck. They're hot to work in. They can be a little bit dirty. That means you're probably going to have to change them pretty often. From an infection control purpose, you'd have to change them after each and every patient. Can we bear the cost of that for an outcome that is so nebulous? Probably not. What do I mean by that? The cost of gowning for each and every patient when you don't have something like swine flu in your country will limit the amount of service you can offer to patients, or it's going to increase fees, one or the other. So it's again, professional judgment. Back home, I don't even wear a jacket. I practice not in these pants. These are expensive pants. But I wear just a shirt. It gets covered like your dental jackets do. I don't wear the same shirt again because it's got perspiration and arm sweat and all that sort of stuff on it. I mean, I would stink the next day if I wore it again. So it goes into the laundry, just like a dental jacket would, all right? So it's very much a professional judgment. For our hygienists, scale and cleans, as you saw, if you only have low volume evacuation, generate a lot of aerosol, a lot of droplet spray, and there's no reason that they should have to wear that stuff home on their clothes, all right? So you have to use, if you're doing fillings in a clinic and so forth, the amount of garbage you get on your clothes is negligible. But if you're doing a scale and clean, it's quite good, especially unless you've got high volume evacuation. That just made all the difference in the world. That video goes for 15 minutes and I just cut out a little bit of it. I didn't show you all the time we spent on high volume evacuation because there was nothing to show you. Nothing happened. Okay, airborne we've talked about. The one, measles, chickenpox, mycobacterium, tuberculosis. I prefer the surgical masks for you unless you're going to get fit tested. Hands up here who's been fit tested in the last 12 months. Hey, wow. Wow, one and only. That's fantastic. She can wear a P2 mask. The rest of you, nah. You stick with the surgical. You're not fit tested. Neither am I. My fit testing was done 2.5 years ago. All right, I'll skip that. This was a thing in an advert on the Australasian Dentist which says that a pre-mouth rinse will reduce your airborne infection. Again, I say to you, airborne infection is based on the pathogen. You need to know which one you're dealing with. For the majority of dental practice, I'm not saying a pre-rinse is not a good idea. I'm just saying that you can't say that we're going to create airborne infections just because we use high-speed drills. That's not what it's about. Airborne infection depends on the germ. It depends on the pathogen. You don't get airborne infection from streptococci. These little critters were the bed bugs, and they were taken off people in Vancouver. These little ladies in a rather rough area of downtown Vancouver were brought in from a nursing home, and they took these bed bugs off them, and the bed bugs were full of blood filled with MRSA. And they didn't know if they'd got the Staph aureus from the little people that had the bed bugs crawling on them, or whether the 5 people all had MRSA, whether it had been spread by the bed bugs. So jury's out on that, but interesting little things you come across in infection control. If you look for it. Batch identification, I hate it, but you're doing well, so keep going. Yeah, the new changes, you can't practice if you are infected in any way. There are good treatments. You can now get boceprevir and there's another one. They're both protease inhibitors for hepatitis C and used in conjunction with pegylated interferon and ribavirin. We can pretty much get almost effective treatment in anyone now with hepatitis C. So if any of you do happen to get exposed to hepatitis C, which I hope you don't, but it might happen, there are some treatments now that bring the results up to, they're not pleasant to take, they actually suck like hell. They're disgusting treatments, but they are effective, and once you've been treated you would be able to practice again. So hepatitis C is not like HIV, which even with meds we can get the viral load to virtually undetectable, but the way the dental board and everyone else is structured, they make it very difficult for dentists to practice if they're infected with HIV. New definition on exposure prone, look it up because I want to skip through. I can see everyone's getting pretty restless. The exposure prone procedures are classified according to ones most of the time. If you look at your fingers when you're doing a filling, they're actually outside the patient's mouth most of the time. And then there is other times when they might be inside, but you're still not at risk of cutting yourself and hemorrhaging all over the patient. But there are procedures we do which are exposure prone, and they include oral surgical procedures, periodontal surgical procedures, endodontic surgical procedures, and implant surgical procedures. All of those are exposure prone, and in fact all of them are critical procedures. Clean and contaminated zones we've already discussed, and the general work surfaces must be cleaned. Incidentally, your cleaning regimen was very good this morning. I thought your cleaning was excellent. And I wouldn't change it. I think a system is good. I think when you get out into private practice, you need to make sure that you get that same attention to detail happening. Okay, I had the privilege of watching some students work this morning, and any good practice will be, private practice will benefit from students learning excellent infection control, and that means knowing how to clean an area up, and so I was quite impressed. I thought that was good. Okay, just on contaminated zones, which you can read later. These are pretty much all just standard precautions, and now we get on to why we're expected to be perfect. This is a medical practice, not going to say where, but that's their sterilisation room, and I don't see any documentation. And I certainly, it's next to a sluice toilet, the steriliser. And, you know, they think dentistry's, you know, like, how good are we, guys, right? I could go into any of your private practices and I know they'll be exemplary. And yet the government still doesn't get it, that the reason that we pick up on things when they go wrong is because we're actually monitoring it so well. Maybe that's our mistake, maybe we shouldn't, then they wouldn't know about it. No, I didn't say that. I seriously didn't say that. You know, like, this is the sterilisation room. I mean, come on. That's, yeah. And the instructions for the steriliser were clean, package, load instruments, press start, okay? So that was all the sterilisation in that practice information. There was nothing there about, you know, like it was a pre-vac, there was nothing about running a Bowie Dick or anything like that. No checking of seals, it was just press start. nothing about, have you done a warm-up cycle or anything like that. And look at in a dental, this was due for demolition on the right. That was a big practice in Adelaide, and they were in the process of redoing their steri area. But even before they redid it, you can see it's like chalk and cheese. There's dentistry, there's medicine, and I don't cease to be proud of our profession. I think we're very good at what we do. But we did give HIV. It was the first transmission in healthcare scenario was in dentistry. So that's why I gave you a history lesson. Why are you sitting here? Because we did it first. We got 6 people, they all died, and some of them died less than 10 years after they got infected. It was very, very quick. It was a very, very virulent virus that he had. He died of AIDS not long after the whole thing happened. So we will live with that now forever because we got really, really good, and now we know when we make mistakes. Other people don't even know half of the stuff that we do. And if you, like on the NH&MRC committee, they think dentistry is brilliant because they understand us, but it's the governments don't. They still don't get it. They still think we're going to do nasty things to people. We're not always perfect. You can't have a fan next to a steriliser, and that's a real crappy setup. And we're not like, people that, do a little bit for you and a little bit for me and manage to give 50 women hepatitis C. So, we really are good. Now, I've worked for 22 years. I've seen about 444,000 appointments. I haven't got HIV, none of my staff got HIV, and no other patients got HIV from the people that I saw. So they're the old bugs. The new ones, the one that I can't find in any of the guidelines is human papilloma.